good night yesterday. We're here today to talk about bariatric endoscopy. I'm sorry that my moderator, Mohit Bhandari, is not here, but I have the best substitute I could get. It's Sai Pichamo from Boston, and the other chair is Roberta from Milano. And I hope we will have a really exciting session today. And I give the stage to my co-moderator.
Thank you. Good morning also from my side. Yeah, it will be an exciting session, I hope so, and we'll do also our best to make it possible. The first speaker, I'm very glad to introduce her, Silvana Perretta from France. She is the Chief of Foregut and Advanced GI Division at IRCRAD in Strasbourg. And her talk today, it will be about endoscopic procedure from training to clinical application. So it is a very great topic. The stage is yours, Silvana.
Thank you. Thank you very much. Good morning, ladies and gentlemen. I'm delighted to have a full chairs of ladies. So it's very, very nice, and it's a change. So we welcome this kind of changes. I think that everybody had a fantastic evening yesterday with a lot of partying, so I'll keep it straight to the point. I'm going to try to wake you up a little bit. I'm going to talk about how we go from training to clinical application. And first, I'd like to define what is bariatric surgeons. I don't know how many surgeons and how many endoscopists in the room, or surgeons endoscopists. I think mostly surgeons. So if you want to go into flexible endoscopy, apply to the bariatric field, you have to know how to treat complication and use it to do so, how to bridge surgery, learn how to perform primary procedures, revision after bariatric surgeries. Those are all useful application of bariatric endoscopy. So what should you learn? Understand obesity, understand obesity pathophysiology, how to manage obese patients. You cannot do a bariatric procedure if you know nothing about obese management and if you do not work in a multidisciplinary team and in a center that can offer you that. You have to understand the normal anatomy and the modified bariatric anatomy. That is a no-brainer for surgeons, but I have to keep in mind that there is an anatomy inside out. So if you're familiar with the outside anatomy, you have to learn what you are looking at from the inside. For the gastroenterologist, you have to understand surgical anatomy. How to manage complication? Shall we do only by endoscopy, a combination of endoscopy and surgery, radiology? And then, of course, you have to master the skill for every single device. So, knowing what is bariatric surgery means that you have to know all the bariatric procedures, not only the one that we're doing now, but also the ones that are not there anymore. Historic procedure is very important, and you have to learn how to describe it properly to understand what's normal and what is not. You have to know physiology, and you have to know how physiology can be modified by anatomy. And you have to understand when you're looking at a high-resolution manometry, not just to rely on the report. The same thing is for endoscopy. Unfortunately, we as surgeons, when patients are seen by an external endoscopist that has not is not familiar with bariatric surgery, you find everything. You find sleeve that have been described as bypass, bypass as sleeve, and everything and the opposite of it. So you really have to understand to produce a common language. And of course, imaging is important too. So anatomy, inside out, physiology, and imaging. And this is just an example. What I see in my practice by external consultant gastroenterologists is that very often they say after a sleeve gastrectomy in a patient that has regurgitation and gastroesophageal reflux disease, they say there is no stenosis, the scope passed through, I don't have a mechanical obstruction. Sometimes you're looking at a functional obstruction. So to understand what is what and how you can deal with this kind of complication, it is very important. Welcome to the panel. And then you have to understand how it works, the connection between the brain and the gut. And to be totally open with you, I'm still learning because this is a very, very complex field. But if you're doing metabolic endoscopy, you cannot be talking about it if you don't understand it, if you don't have at least the basics. And then you have to understand every single device if you want to use it. And to do that, you have to go and train with people that have a profound knowledge on how it works. Multidisciplinary team is fundamental. and not only in the preoperative workup, but also in the postoperative follow-up of patients. You can do a beautiful procedure if you don't have a team in place to take care of the patient and see them regularly at follow-up, you're gonna fail. Because obesity is a chronic relapsing disease, and you have to have everything in place around you to make it work if you want to go from training to a successful clinical practice. Let's talk about hands-on. How should you learn? Of course, you can have e-learning, you can see live session, you can attend courses such as this one, but then you have to start to actually manipulate and train your skills. You can do this with in vivo, ex vivo model with a simulation. You could do it afterwards when you start your case with mentorship, which I highly recommend. And then we can have some innovative data training to personalize your training experience. Know your tools. If I give you the example of the endoscopic sleeve gastroplasty, you have to know how to put it together, how to dismantle this over-the-scope device to perform endoscopic suturing. You have to know how troubleshooting, you have to know how to get out of difficult situation. You have to know what kind of material you're using, what kind of suture you're using. You have to know what you would normally do in surgery. You check your table, because in the end, you're the one who's responsible, not the nurse, not the rep who's in the room. So really take your time to train. And once again, anatomy. So a lot of surgeons tell me, I know anatomy, I'm a surgeon. What you don't know is how doing an endoscopic procedure will modify that anatomy. For the gastroenterologist, you have to know where the spleen is, you have to know where the short gastric is, where the pancreas is, you have to master all this knowledge in order to be safe and effective. Patient positioning. You have to choose what you want and how you want to start. I always recommend to start with the patient lying down. You have to understand that when you move the patient, you move the organs. Play with gravity will help you. Talk to the anesthesiologist. You cannot do a case if the anesthesiologist is not comfortable. You have to have a stable and safe working environment. And then in the lab, use every single option that you have in a step-up approach. In vitro first, then ex vivo, and then only then in vivo if only it is necessary. Try to reduce the use of animal if it's not necessary. Why? Because it's much more complex. In a confined in vitro environment, you can actually measure skill much better. Train on a specific task in the simplest way possible. We use plastic models in order to train how to place stents, and also Daxion models, which is a very, very cheap way so that we can democratize training and bring it everywhere. Simulation. Patient-specific simulation, procedure-specific simulation is very helpful. For ESG, you can now try to produce the perfect suturing training specifically on a particular suturing pattern on that particular patient's stomach. So today we have a level of I would say, high fidelity doing this that is really, really helpful, and is going to also help you monitor your progression and learning curve. And then you can train home. We developed this plug-and-play simulator that you can plug to your Mac or to any computer that you have, and you can go home and continue training. And this is important because if you attend a training course and then you wait 3 months until your next procedure or your first procedure, that time is something that will decrease your level of skills. Pick your mentor and coach. You want people that are extremely comfortable or working in high volume and large volume facilities that have experience and that know the procedures that you want to learn. Now, learning curve. We can say everything and the opposite for the learning curve. If you look at the level of difficulties of procedure, for a simple procedure, maybe you need 10 cases. For a more complex procedure, you need 20 cases. If we look at ESG particularly, in order to throw some sutures and design a gastroplasty, probably you need 10 cases. But to reach a level of efficiency with no outliner that is translated in a very effective procedure, you might need 40 to 50 procedures. I personally got rid of the outliner after about 50 procedures. So now I know what kind of results I can give to my patients. Duration of training depends on what you want to learn. If you're experienced, maybe 1 to 3 months. 3 to 6 months or more if you have less experience. I think that competency is the key. You have to measure how good you are in order to improve. Certification are important too. SAGES and also SMBS are now delivering a B-Safe bariatric endoscopy training. It is important, very much so, especially in those countries where that is not exactly easy for surgeons to practice endoscopy. So go get certified. So in conclusion, what should you learn? Learn, of course, the basic knowledge of bariatric anatomy and surgery. Do not forget about physiologists. Do not forget about the patient. Weight is not everything. Measure your competency and try to train in centers of experience and expertise, and then find the right mentor and ask them to shadow you with your first cases. And then, of course, never forget the multidisciplinary team. Thank you very much.
Thank you so much, Silvana. So we're going to keep all the questions towards the end of the session. So it's my great honor to introduce the next speaker, Dr. Barham Abudaye. He's an Assistant Medical Director of Business Development, Vice Chair of Innovation, Director of Advanced Endoscopy, and Full Professor of Medicine at Mayo Clinic. Thank you.
Thank you. Thank you, colleagues, for showing up to this session tomorrow. If I could have my slides. There we go. All right, so today we're going to talk about endoscopic sleeve gastroplasty, and we're going to talk primarily about the mode of action. I have one simple task, and this task is you all should walk away with a clear physiologic understanding of how endoscopic sleeve gastroplasty work. And it's simple, and we're going to break it down, and hopefully I will achieve this task by the end of this 10 minutes talk. All right. It's not moving.
Can we have technical support?
All right, so these are my disclosures as it pertains to the purposes of this talk. Are you going to change it for me, or is clicking it from here? I should have been as smart as Dr. Peretta and got my own laptop, but I was not, so.
Abbiamo bisogno di assistenza.
I could sing, yeah. All right, I think we're in business. All right.
Okay.
So first of all, we're going to talk about briefly the unmet need for procedures like the endoscopic sleeve gastroplasty. And basically, the big unmet need is the prevalence of obesity is reaching about 60% in the United States, to the level that we're running out of shades of red. And now we're introducing a new color to the map, which is blue, indicating a prevalence of about 60%. So right now, most of the disease burden is going unmet, with less than 1% of patients who qualify are getting either medications or bariatric surgery to manage this disease. So we need more options to treat our patients. Oops, all right. So ESG represents an organ-sparing way to manage the patient. It's safe and effective, has no long-term consequences to health, and most importantly, it's minimally disruptive to the patient lifestyle, because for this disease, the best intervention is the one that the patient could follow. Therefore, it has a role to play in the management of obesity and its metabolic dysfunction. So most of the talk is going to be focused on ESG, the anatomy and physiology, and hopefully we'll walk away from this lecture with a clear understanding of how it works. To understand how it works, we have to have a quick one-on-one course in human appetite. That's fundamental. Human appetite is two processes. There is satiation and satiety. You all had breakfast this morning. Some of you had 200 calories for breakfast. Some required 800 calories. So this is the time to terminate the meal and that's primarily a function of gastric accommodation. You could see the fasting stomach on SPECT imaging, and the stomach triples in size after a meal. This change in the volume of the stomach communicates through the vagal afferents to the brainstem and the hypothalamus, and you terminate that meal. So that's part one of the human physiology that we're affecting. Second is after you ingest that meal, the meal is going to empty at some rate, and that's governing satiety, is what's the intermeal interval. Some people get hungry within an hour, some people take 4 hours, and predominantly this is a process of gastric emptying. So we're going to give you evidence that ESG simply works by augmenting satiation and satiety, and that's how it produces weight loss. The way it conveys this is this highway that is called the vagus nerve. 80% of the vagus fibers are sensory fibers to the brainstem and to the hypothalamus. And you could see why the first difference between ESG versus the laparoscopic sleeve is that the lateral greater curvature branches of the vagus nerve are being removed in surgical sleeve gastrectomy, and they're maintained in sleeve gastroplasty. That's why it augments normal human appetite. So the procedure is taking a stomach, using full thickness suturing, starting at the level of the junction between the antrum and the body, imbricating the greater curvature of the stomach to do two things: shorten the length of the stomach and tubularize that greater curvature. These anatomic manipulations result in physiological changes in both the accommodation and emptying of the stomach, and hence improve satiety and satiation to produce weight loss. This is SPECT imaging of how the procedure looks. You could see this is radionucleotide labeled meal. You ingest that meal goes into a small fundus. This fundus accommodates quickly. You terminate the meal at lower calories. Then there's the tubular portion of the stomach that delays the emptying of that meal, but once that meal gets to the antrum, it exits from the stomach, so you're both affecting the accommodation and the emptying of the stomach. So we did this very fancy physiological study using MRI, which there were very costly studies. We published this in Gut, and you could see here, this is 3 months after the endoscopic sleeve gastroplasty. You could see the imbricated greater curvature of the stomach. You could see the small cap in the fundus. You could see the tubularized greater curvature. And what's more important, you could see a contractile antrum. So the procedure delays gastric emptying, but does not cause gastroparesis, because once the meal makes it through the tube, it makes it to a contractile antrum and exits from the stomach. So how does ESG delay gastric emptying? And here we've shown that simply it does not cause paralysis of the stomach. Here you could see the waves of what empties the stomach before the endoscopic sleeve gastroplasty. You could see you have 3 waves per minute, and these waves are starting in the proximal stomach and going toward the antrum. Simply what we're doing after sleeve gastrectomy is these waves are, instead of starting in proximal stomach, they're starting in the antrum. So they're becoming short, but they're existing at the same frequency and at the same strength. And that's clearly how it delays gastric emptying without causing gastroparesis. And this is part of the MERIT trial. So this is randomized data that looked at the time to empty the half meal between the sleeve gastrectomy or sleeve gastroplasty and the control. And you could see that there is a significant delay in after sleeve gastroplasty from 83 minutes to almost double the emptying at 3 months, and most of this delay is maintained at 12 months. So if people have doubts about durability, you could see physiologically the construct is functioning as it was at 3 months, at 12 months. This is now the accommodation side of things. You could see here's the stomach before the sleeve gastroplasty. This is the stomach at 3 months after, and then at 12 months after. You could see that the construct is fully intact at 12 months, and you could see that the fundus is accommodating much quicker after the sleeve. That's why affecting the gastric emptying and accommodation. So now a brief, after hopefully everybody got the way that this procedure works. Now let's take a quick tour of the evidence. The evidence is quite mature. About 16,000 papers in the published literature. The pooled SAE rate is about 1.2%. 12 months total body weight loss is about 17.5%, and this weight loss is maintained at the 3 years horizon. So this is a synopsis of the evidence. Based on this evidence and a multi-center randomized controlled trial published in The Lancet in the United States, the FDA issued a clearance for the endoscopic sleeve gastroplasty for the treatment of class 1 and class 2 obesity, and actually class 3. So the BMI range is 30 to 50 for this procedure. This is the MERIT trial. In blue is the ESG arm. In red is the moderate intensity lifestyle arm. You could see that there is about 50% excess weight loss in the ESG arm, with a 45% difference for moderate intensity lifestyle. Responders rate is about 77%, and those who responded achieved about 16.3% total body weight loss. The intriguing part about the MERIT is the second half of it was done during COVID. And people who got moderate intensity lifestyle crossed to get the ESG, and you could see that despite COVID, they reached identical weight loss in the second year of the study. And those who had the procedure in year 1, we had another year of follow-up, and they maintained, despite COVID, the majority of the weight loss. So there is improvement across the board in type 2 diabetes, metabolic syndrome, and hypertension, not only clinically, but based on objective measure of HOMA-IR, hemoglobin A1C, hepatic steatosis index, and inflammatory markers. And there was only 3 serious adverse events that are including 1 perigastric abscess managed endoscopically, 1 case of upper GI bleeding managed also conservatively, and 1 case of malnutrition that required endoscopic reversal of the procedure. No patient required ICU stay, there was no surgical intervention, and there is no ICU stay. So to end my talk, this is the chiasm that we're dealing with in the management of obesity between surgical and lifestyle intervention. Medications are getting better. Endoscopy, like ESG, could meet the medication weight loss, but also endoscopy is getting safer. So in 2023, you have both endoscopic and pharmaceutical options as first-line therapy for the treatment of obesity across a broad spectrum. And with that, I conclude that ESG alters human appetite pathways to induce weight loss by affecting gastric emptying and accommodation. ESG is associated with clinically relevant weight loss. It is a safe and effective procedure. Most importantly, it's a scalable procedure that could increase access to a wider segment of the population with metabolic diseases and obesity. Thank you for your kind attention, and we'll take questions at the end.
Thank you, Barham. It's an honor to introduce to you my great friend Ayad Al-Katani from Saudi. He is not here, so he'll be speaking on is the ESG appropriate solution in treatment of adolescents with obesity. So we'll have his recorded lecture played. Can we have his lecture played, the AV team?
Thanks for the invitation. We'll be talking about endoscopic sleeve gastroplasty in children and adolescents. We know the comorbidity of obesity in children and adolescents is significant from head to toe. Any organ can be affected. Diabetes is really growing and seen more frequently in children and adolescents. Before it was a disease of adults, now we see it more frequent in children and adolescents. Sleep apnea is also very frequent and a problematic comorbidity in children. We can see 40% of obese are having sleep apnea compared to 3%. That will result in neurocognitive impairment, cardiovascular disease, renal impairment, systemic and pulmonary hypertension. Hypertension itself is very common in obese children and adolescents. And liver disease, fatty liver and NASH are also common, up to 60%. They will have some degree of liver injury and reaching to cirrhosis and irreversible damage. This is, we have proven it by biopsy. Quality of life is similar to cancer patient, unfortunately, and that is with the success of bariatric surgery and the need for this obesity comorbidities, we need something to provide for these kids. And it ranges from lifestyle medications into bariatric and surgical intervention. Unfortunately, lifestyle intervention is not very effective and not durable. Similarly, it has been shown in many studies. Similarly, semaglutide and anti-obesity medication is not very effective and not durable. Compliance is very low and rebound is very frequent. It has been shown that those who are on semaglutide or liraglutide can regain their weight very quickly compared to placebo. The best intervention for treatment of diabetes is surgical, and this has been shown in adult as well as in pediatric. We have shown and proven that sleeve gastrectomy is the best option in these patients, and we have studied multiple groups in different age group and different type of BMI and different duration of follow-up. 10 years follow-up showed that those patients who underwent sleeve gastrectomy can maintain weight loss up to 70% total excess weight loss at 10 years, comorbidity from 60 to 70% resolution, and growth is maintained and even better. Also, we noticed that comorbidity resolution will happen in the first 3 to 6 months. Those who are syndromic also can help benefit from bariatric surgery as well. Unfortunately, only 0.04% can benefit from bariatric surgery. The other, either due to access to care or other cause, they are not getting the bariatric surgery. For that reason, it is very important to find other solutions that can provide better access to care or better outcome in terms of those who are not candidate for bariatric surgery. We are talking about endoscopic sleeve gastroplasty over stage technique, where you go inside the stomach and do a square button or U-shaped button or different patterns. There is no difference in outcome. If you look to the video from outside, you will find it is full thickness, and from inside you will find it's a tube-like structure and almost reducing the size of the stomach, the volume, by 60 to 70%. We compared it in adult to LSG, and we found weight loss is within 10% total weight loss from LSG. So if LSG 30%, you will find ESG 20%. Comorbidity is not different. There are significant resolution. Both procedure at first event is not significant in both procedure, and revision in ESG can be done to any techniques. You can redo it and do procedure, another procedure, sleep or others. We incorporate it in our pathway, where we do it for those who are not candidate for bariatric surgery or fear of they are really fearing bariatric surgery or not accepting bariatric surgery. In this group, we have done ESG in 253 patients up to 4 years follow-up and showed that it can result in significant weight loss and resolution of comorbidities. No significant morbidity associated with it. They will visit emergency room for rehydration or outpatient clinic for rehydration or analgesia, but it's not significant, and this is shown also in adult. Brazilian consensus did not reach to a minimum age, and in fact, they are recommending more than 12 years of age. 40% will recommend more than 16 years of age, so still no consensus on the age in that regard. Denial of bariatric surgery is unfortunately common, whether endobariatric or bariatric. They are not referring patients below 18 or 16 years of age, and this is very common scenarios. Unfortunately, most of the people will not refer even to ESG unless they are more than 18 years of age. In our practice, we do it 10 years onward, 10 years of age onwards. So in summary, childhood obesity is associated with multiple comorbidities affecting patient lives. Non-interventional lifestyle change and medical therapy are minimally effective and not durable, and compliance is very low, and relapse is very high. In children and adolescents with class 1 and 2 obesity, endoscopic sleeve gastroplasty using upper stitch induced significant weight loss without mortality or significant morbidity. ESG serve as a middle ground solution between lifestyle behavioral modification and bariatric surgery. ESG fills a critical gap by offering solution for patients not eligible for bariatric surgery, fearful of bariatric surgery, or contraindication for bariatric surgery. Children and adolescents who suffer from severe obesity should be referred to multidisciplinary team that provide different solutions, including endobariatric. Thank you.
Okay, now we'll move to an in-person speaker, and I'm glad to introduce Said Pichemol-Girapino. She is Associate Director of Bariatric Endoscopy in Harvard Medical School in Boston, and she will talk to the primary obesity surgery, endoluminal transoral endoscopic gastroplasty, development of technology from transoral endoscopic gastroplasty 2 and 3, because we haven't... Sorry? Yeah. Because we have understood the mode of action. Yeah, it's a very long title.
It is indeed. Thank you so much, Roberta, and I'd like to thank IFSO, Christine, Mohit, for the invitation. It's lovely to be here and see a lot of familiar faces. So today I'm going to be switching gears. Now that we heard a few wonderful talks on ESG, we're going to be discussing POST next. So what's the difference between ESG and POST? When we talk about ESG, this is when we utilize an endoscopic suturing technique, which refers to when you oppose the tissue in a mucosa to mucosa fashion. It's not moving the slide. In contrast, when we talk about POST, this is when we utilize endoscopic plication, which refers to when the tissue is approximated in a serosa to serosa fashion. During the POST procedure, we use an endoscopic gastric plication device called the IOP system. And this is how the device works. So you start by using a G-helix or a tissue helix to pull the tissue into the approximation device. You then pass the needle through the tissue and drop the first tissue anchor. Remove the helix and then drop the second tissue anchor on the other side of the tissue and then cinch both of them together. After that, the suture is then cut and released. So this is one plication cycle, and then you repeat it within the stomach. Originally, the POST procedure was performed by placing plications in the gastric fundus. As you can see here, you go in and retroflex the IOP, or the transport, and then start plicating the gastric fundus. And the goal here is to reduce gastric accommodation after eating. After you place several plications in the gastric fundus, you unretroflex the transport and place a few in the gastric body. So what's the efficacy with the original POST procedure? From the Essential trial, which was the US multi-center randomized sham-controlled trial combining POST with low-intensity lifestyle modification, POST procedure was associated with about 5 to 7% total weight loss. However, if you combine POST with moderate to high-intensity lifestyle modification, the amount of weight loss went up to about 13 to 18% total weight loss at 1 year. So how did the POST procedure, the original one, how did it work mechanistically? Here's a study from the Spain group looking at 18 patients who underwent original POST. What they found was that after the procedure, patients had greater inhibition of ghrelin and also greater enhanced simulation of PYY. So what this means is that after patients eat, they had a greater drop in ghrelin and a greater increase in PYY, so they become less hungry and fuller much sooner compared to prior to the procedure. Additionally, they found that gastric emptying was delayed after the original POST. So now that they knew that Pose can delay gastric emptying. This is one of the reasons why our group came up with a newer technique called distal pose 5 years ago. During the distal pose technique, we place plications primarily in the gastric body, sparing the fundus. This is how we currently perform the distal pose procedure, and we called it a double helix distal pose procedure. As you can see, we start at the incisor, utilize 2 tissue helixes to pull a lot of tissue into the approximation device. Pass the needle, drop the 2 tissue anchors, and then cinch them together. And you can see that with only 1 plication, you can significantly reduce the gastric lumen at the incisor. And the goal here is to focus on narrowing the gastric lumen. So here, we're moving on to the second tissue plications. Again, at the incisor, but you start moving towards the lesser curvature side. For this technique, it's very important to work further away from the tissue. This way, you can get a bigger tissue bite when you grab the tissue. And here you can see that after the second tissue plication, the incisor is pretty much gone. After that, you start moving up to the gastric body, and here we're gonna focus on shortening the gastric length. So in order to do that, you rotate the G-prox, or the approximation device, 90 degrees so that it lies parallel to the gastric length. And again, you pull the tissue in with the gastric helix, close the tissue plication, drop the tissue anchors, and then cinch them together. After you work in the gastric body, you move up to the proximal body, and here we're gonna focus on narrowing the stomach at the top. So you're gonna rotate the G-prox back so that it lies perpendicular to the gastric length of the stomach. And here we're using the 2 tissue helix so that you can get more tissue and then plicate it. And this is the final look after the pose procedure. So what's the efficacy with the distal pose procedure? Here's a single center study from our group looking at 110 patients. At 1 year, patients experienced 15.8% total weight loss. There was 1 patient who had gastric perforation, which was treated successfully with surgery. Additionally, in this study, we found that the double helix technique was associated with greater weight loss compared to patients who underwent the single helix technique. Specifically, the amount of weight loss went up to 20% at 1 year in the double helix group compared to 13% in the single helix group. Additionally, at 1 year, 95% of the patients who underwent the double helix technique achieved at least 10% total weight loss compared to 58% in the single helix group. Shortly after, a group from Mayo and also 2 sites from Spain reported their 3-center study on patients who underwent POSE 2.0. So what is POSE 2.0? So this is essentially the same concept where plications are primarily placed in the gastric body, sparing the fundus. However, instead of narrowing the stomach at the incisor, you shorten the stomach at the incisor. Additionally, in the gastric body, instead of shortening the gastric body in distal pose, for POSE 2.0, they focus on narrowing the stomach at the gastric body. So from this study, they found that the efficacy at 1 year was 15.7%, and there were no serious adverse events. Moving on to other indications for POSE. So POSE can also be performed in patients who had obesity and concomitant GERD. We now know that patients who had class 1 obesity and acid reflux is a challenging group to treat. Why is that? Number 1, fundoplication is suboptimal when patients have obesity. 2, sleeve gastrectomy may worsen GERD symptoms. Additionally, Roux-en-Y is rarely performed when patients only have class 1 obesity. And therefore, you can use this IOP system to perform both anti-reflux and POSE procedure. As you can see here, we go in with a transport, retroflex, and place several plications. On average, we place about 8 plications at the GE junction to tighten the valve. After that, you unretroflex the IOP, and then do the distal post procedure. I actually just saw my patient who I did this procedure 3 years ago last week, and he's still doing wonderfully from an acid reflux standpoint, remains symptom-free of PPI, and his weight loss is about 10% at 3 years. From my experience, when you do a combined reflux and anti-obesity procedure with this device, patients tend to do really well from an acid reflux standpoint. The amount of weight loss might be slightly less compared to when you only do distal post. Usually it's about 10 to 12%. Additionally, you can also do post-procedure for patients with MASLD or fatty liver. Here's a study from our group looking at 45 patients with obesity, MASLD, and F2 to F4 fibrosis. What we found was that at 1 year, there were significant improvements in non-invasive tests for hepatic fibrosis. Specifically, ALT decreased from 49 down to 24. There were significant improvements in NFS and FIB-4 scores. Additionally, on FibroScan, liver stiffness score went from 13.9 kilopascal down to 8.9 kilopascal. Additionally, moving up to patients who are sicker, here's a study from our group focusing on patients with advanced fibrosis, and about 50% of them had portal hypertension. In this study, we recruited patients, 20 subjects, all of them had advanced fibrosis. We performed post and then checked their portal systemic pressure gradient, or PPG, prior to and 6 months after the procedure. What we found was that at 6 months, patient had significant improvement in PPG. Specifically, the average PPG went from 5.4 down to 1.8 millimeter mercury. Additionally, 80% of our cohort experienced at least 20% reduction in PPG, which previously have been shown to translate to a reduction in mortality. In conclusion, POST appears safe and effective at treating obesity. Traditional POST focuses on placing plications in the fundus. In contrast, distal POST and POST 2.0 focuses on placing plications in the gastric body. The double helix technique is associated with greater weight loss compared to the single helix technique. And last but not least, POST may be considered in patients with obesity and concomitant GERD, or patients with MASLD with advanced fibrosis, including those with portal hypertension. Thank you very much.
Okay, now we'll move to my co-moderator, to Mohit Bhandari. He's the director of Mohawk Bariatrics and Robotics in Indore in India. And his topic today will be the swallowable balloon, professional treatment of obesity or preventive lifestyle intervention that anyone can apply.
Thank you very much, chairpersons, for giving me an opportunity to talk about the swallow balloon. This is our university in India where we work. These are my disclosures. I had the honor of getting the mentorship of two of the most sharp and brilliant bariatric surgeons, Dr. Phoebe, and now working with Manuel. These are my disclosures. So if we look at our case mix, it's very fascinating why a surgeon like me, who has performed 22,000 bariatric procedures, would try to choose something like a swallow balloon in his own practice. And this lecture would also reflect a lot of insight into how the business of obesity as such is moving across the world, even considering this entire meeting in perspective. So, we need to talk about some very hardcore facts about what problem we are facing. Obesity is a very chronic disease. So no matter what you do, it's going to fight back again and again. Probably it is the most recalcitrant disease on this earth. Every time we do something, in years to come, we will have a recurrence. No matter you do a duodenal switch or any form of surgical procedure, it's like malignancy. It fights back, and we always need to have a multi-pronged approach to treat it. The problem is, every year, as things pass off, we stop to study the patient behavior. Now, as a bariatric surgeon, I did this study on my patient behavior where only 1% of the patients who walk into my OPD would select bariatric surgery as the solution. So if I have a huge bariatric OPD, only one patient out of 100 would get that done. They would not want to disclose it to anybody that they have done it. So they want discreetness and confidentiality. They are very scared about the invasive behavior of bariatric surgery. And whenever they read something on social media, it scares them further, so they do not want to seek the treatment of their obesity. Now, all of us know, and this, we talk, but we do not put it into our practice, that we do not require 100% access weight loss for the treatment of our comorbidities related to obesity. It's just the 10% of total weight loss, or maybe 30 or 40% of excess weight loss. But what as surgeons we are doing every year as it passes off, we come up with a new bariatric procedure. And there is no problem in having a new bariatric procedure, but at the end of the day, we fail to understand that we are not trying to increase our reach. We are just struggling in that 2%. So every year, some surgeon will come up with a new modification of GI tract, would claim that this procedure causes 2% more excess weight loss than the previous procedure. But what we do is, in this hall, we struggle for that 2% amongst ourselves, and we try to form a part of the cult. There is a MGB group, there is a sleeve group, there is a bypass group. Now there would be a transit bipartition group, and every other group will claim in every coming year that this has 1% more resolution of type 2 diabetes, 2.5% more resolution of weight loss or something like that. But the problem is there is a whole treasure of 98% which remains, and nobody is talking about that. So that's where we, can I change it? Still not working. Same problem. No, it doesn't go. So can you change it from there? Okay, so what we need basically is, even as surgeons in my practice, I wanted something very less invasive, very temporary, without risk, so that I can funnel patients into my system, and then I can choose them, or maybe, inspire them to do a bariatric surgery later on. So confidentiality was my need, discreetness, safety, something non-surgical, something which maybe I can do in this room. Something which has no surgery, no anesthesia, no endoscopy, a complete outpatient procedure. Because that is something which could have helped me funnel those patients who were blocking my mobile phone because I was offering them a surgery. Believe me or not, every time you are perceived as a surgeon, or even as an endoscopist who gives anesthesia, shorten the stomach or tighten the stomach, there are patients, and 98%, whole lot of them, in the era where medicine claims to treat obesity, who would not want to talk to you. And what I got, when I searched about something like that, I found this device, which is known as Allurion swallowable capsule, because that's something where you can swallow a capsule in the outpatient clinic, converts into a balloon, just like any other intragastric balloon, which gives an hour of general anesthesia. This can be just done 15 minutes as an outpatient procedure, and I wanted to target the 98% of those whom I cannot touch as my patients, or I cannot transform their lives. I know I'm not talking about 80% excess weight loss like a 1 anastomosis gastric bypass. No, I'm not talking about maybe a 60 to 70% of excess weight loss like an endoscopic sleeve, but who wants it? The 98% would not want them. And I want to funnel those patients into my own bariatric practice, so that someday, by giving them that optimization kind of weight loss, I can do their bariatric surgery or a bariatric endoscopy. That was the whole trick. Now you see my trajectory. We started with sleeve gastrectomy, we came down to banded procedures with Dr. Phoebe, did all best possible kind of procedures to avoid weight regain, but guess what? Every time these patients, apart from those who have done a banded procedure, came back to me with weight regain. And all they wanted is something non-invasive, so we started bariatric endoscopy. I told Manuel we want to start the Allurion program, and we were committed. And you see the progression from 48 cases to 1,400 cases a year. Still, I am in need of a procedure like this, where I don't have to do an endoscopy, anesthesia, surgery to funnel in more patients. Now, my practice has suddenly increased of bariatric surgery, because the patients I'm doing a swallow capsule, after a 1 or a 2 time swallow capsule, comes to me back for a bariatric surgery, because now they have faith in me that I am not after them to cut off their stomach. The point I'm trying to make it that this particular device is trying to prove, or maybe other devices, I'm not talking about one such device, but these devices are trying to teach us a lesson. In an era where drugs are going to take over 80% of obesity practice, we have to see what IFSO Global Registry teaches us. It says that the number of procedures have stagnated, they have not increased. And not only that, the treatment of obesity is undergoing a paradigm shift where that 98% would lead the market, where drugs and devices like swallowable capsules or Allurion or maybe different others are going to rule this world. This is good because they are not only doing something, they are also monitoring it. I have never given a weighing machine to my bariatric surgery patient, but now I am giving a weighing machine to all my post-bariatric surgery patients, and when they see their weight and I get it on an app, I know that this data documentation is much more secure than calling them on a mobile phone and getting their weights done. Because they stand on the weighing machine, it's connected to an artificial intelligence app, the data comes to me, and I'm very happy about that. I'm not going to go into the details of how efficacious this product is, but the point I'm trying to make is that we do get good amount of weight loss even with this. And good means I'm not talking about 30% total weight loss, but I'm talking about 10 to 15% of total weight loss, which is good enough for my patients. Why it is good enough? Because it prepares their liver. The NAFLs come to me where I cannot do a gastric bypass. I prepare my patients and optimize them with a swallow balloon. And then I call them back. Obviously, the procedures will have some contraindications like they've shown here, it's not a magic bullet, but it is very extensive follow-up, whereupon these patients talk to us almost every week through the connected app. And because now we are following up them very vigorously, the faith between me and my patients have increased a lot. So the balloon comes out in 4 months, automatically in motions for those of you who do not know. It's just a swallowable device, 15 minutes of outpatient procedure, but this is very important. I was putting intragastric balloons in my practice previously by doing general anesthesia, and it gave me a bad name. Those patients never came to me for bariatric surgery. For some reason, I don't know, because there are less complications of general anesthesia. Most of the complications of intragastric balloon in the first 15-20 days were because of the complications of general anesthesia, and this device takes us away from that, and this study shows that there is less serious adverse events with this generation of balloon which is swallowable. Again, there would be side effects like nausea, vomiting, and we have to manage them by PPIs and all those things. But the good thing is that the adverse events, which I have seen in my own practice, and I'm going to present my own data now, which shows that it's very less. This is a study from 1770 consecutive balloons where they have shown a 14% of total weight loss. I feel this is good for a 15-minute of outpatient procedure. Again, they demonstrate excellent safety and efficacy. There is emerging role of this balloon in type 2 diabetes, nothing very new here. We know weight loss treats type 2 diabetes. And the HbA1c fall, we have published a similar study in our setup. This is what we published, good resolution of type 2 diabetes with swallowable capsules. And we have done around 1,000 patients in my practice. As you can see, we report the same 14% of total weight loss. And that's good, 32% of excess weight loss, good resolution of type 2 diabetes, 58%, I'm happy with that. It actually puts my patients off insulin, prepares their liver well. I don't know if this video plays. So this is how we practice. I'll finish off in 15-20 seconds. This is how we practice it. We have families doing swallow balloon in our outpatient clinics, one after the other. We put them all in a lot and put 10 balloons together so they get motivation, and they are almost ready to do this procedure, families after families. And these are the patients. They are then funneled into my practice, whom I can offer a bariatric procedure 6 months, 10 months, maybe a year later. Out of the 989 some patients I report here, I have already performed bariatric surgery on 32 patients. These patients would have never come to me to get a bariatric done if I would have offered a bariatric to them straight away. So it's a good thing. In conclusion, I would say that we will be taken away by drugs and devices like this in times to come. It's not good to just stick to that 2% bracket where all of us are and try to develop a new procedure and invest on it. Instead, we maintain our data there at that 2%, try and study more, but we try to get that 98% where drugs and devices like this is going to take over the market. Thank you very much.
Thank you so much, Mohit. Love that video. It's my great honor to introduce the next speaker, who's my dear friend and colleague, Dr. Manuel Galvo-Nido. He's the director of bariatric endoscopy at several centers in several countries, including Brazil and India. And Manuel today is going to be giving a lecture on evolution of endoscopic small bowel interventions, from duodenal-jejunal bypass liner to duodenal resurfacing to endoscopic bypass procedures. Thank you.
Another long title. Mohit, stop typing. Return the clicker. Thank you. So good morning, everyone. I'll try to make it on time. It's a long task. So my disclosures, you decide it's going to be commercial or not presentation. We already know, just mention these two words, diabetes and globesity, and you understand the kind of mess we are in. So numbers, they are there. I'm not going to go further than that. What you have to offer, you already saw that in 2023. We have interventions on the stomach, space-occupying device, remodeling, gastric remodeling procedures. We can alter the anatomy with that. And we have interventions on the bowel in the same path that the bariatric, the metabolic surgeries are doing. And we can detour the path of the food. We can create magnetic anastomosis, and we can alter how the mucosa is with intention to treat metabolic conditions on that. And let's start, and I was asked to guide you to this journey. So I'll tell the history of that will take part. Duodenal bypass, very interesting. Get the scope, wire after the triangle, slide the capsule. Inside this capsule, like a parachute, you have a sleeve, 2 feet, 6 centimeters. You stand that with a traumatic ball to the bowel. Then you open up a stent with barbs. They're going to keep it in the post-pyloric position, as you can see here. And then you detour the path of the food like a biliopancreatic limb of a gastric bypass. So the food passes inside, the biliopancreatic secretions pass around, and you mix like that. To remove, you have a special hood, a special grasper. So you grab a suture on the stent, you collapse, you protect, you remove like a gigantic stinking worm after 1 year. So we were there. You can see here, 2007, the first in human was done there. How it works, so see this graph, inferior, left, so patients lose weight and effectively drop the H1C. And if you see here the weight loss in the long studies we did in South America, it is more than 15%. So good weight loss, good drop on the H1C. And you see here that it was done extensively, even went to clinical practice in Europe and South America. And this is the ESG PV study, and it's passed with flying colors. And you can see here down below, to the left side, this drop of H1C, around 1.5 in all of those single-arm papers. And it is 3 randomized trial, it keeps like that. So long history short, it went to US to do an FDA trial, and the trial was suspended because unexpectedly have much more hepatic abscess that we saw in Europe or saw in South America. And interestingly, Thompson, Chris, and you guys carry it on. So look at this. Even if the trial was stopped, and now you guys published that. So again, inferior left, compare blue with red. Red is the sham, blue is the intervention. They lose weight, and the H1C drops. So, get another chance, leading by you guys, Thompson and Jake, and trials there. Interestingly, everybody misses that. Patients were crying, we were crying. Look, this is post-mortem, but not mortem. And look at this. Even after it was suspended, look at this data is there. 100% total weight loss, 2.7 drop in the H1C. And you want that? Diabetes care, people crying, 10 centers, 1,000 patients. BMI drop and H1C drop on that. That said, it's not dead yet. We got a chance, so Mohit and us, we start in October again. And the company is completely rebuilt on the aims, completely rebuilt on the way we are doing here. Now it's called Morphic, it's called reset procedure, and we are done and back to the game. So 10 years on the road, good weight loss, good drop on A1C. We thought it was safe. We get back. Sometimes it happens when we are starting things, experimental, and we will try to get this on the road again. And then comes the duodenal mucosal resurfacing. Oh man, this is revolutionary if it works. Let's see. So the whole idea is that the duodenal mucosa has a huge impact on metabolic conditions. So you can see here the healthy mucosa, the diabetic mucosa, they are different, and they are have impact on metabolic conditions to that. The idea is, let's show that, let's ablate that, and let something new reborn on that, and to see if it works. So the first one is that you lift the mucosa with a methylene blue solution, and then you apply a circumferential burn with circulating hot water, 87 plus degrees Celsius, from the papilla up to the triangle. It's ambulatory procedures. Patients go home the same day. So again, the history, the same. First in human, and then you go more sophisticated in study. So it's a good drop on A1C on the single arms, and a good impact on the fatty liver, as you can see by your own eyes on that. And then you progress, and you can see here this gigantic study, Europe and South America. And when you take out the confounding factors, you can see good drop on A1C, good drop on good improvement on the liver function, small improvement on weight, but seems significant on that, and the HOMA-IR, so it also improves the insulin resistance on that. And interestingly, look at this. Let's be smart, as Mohit just told us. It's very, very small study. And the aim was to take patients out of insulin and replace that with GLP-1 analog. At the end of 1 year, with one ablation, more than half of the patients were out of insulin. And you're going to say to me, Manuel, what's the point? That's so small. That's nothing. Oh, this is a huge point. Be an American and try to buy insulin, and you're going to understand what's the size of the problem. Oh, Manuel, but take them from one drug to the other? Yes. Insulin is kind of poison. When you start using insulin, you become obese, your liver becoming fat, and the insulin resistance goes up. You change to a GLP-1 analog, you lose weight. The liver shrinks, and the insulin resistance gets better. No, Manuel, but we can use drugs. No, you can't. The possibility of you taking someone out of insulin with drugs is almost zero. So yes, and don't trust Manuel. I'm Brazilian. Why are you trusting me? Trust the FDA that grants them a breakthrough approval. So it should be important. So again, Thompson is and Harvard guys, they are leading the FDA trial, waiting for you guys here. 5 years down the road, not really for weight loss, but good drop on A1C, safe, experimental, but get a FDA breakthrough approval. That's very good. And that's the news. Be prepared, because this is the golden rush. Thermal ablation. And how about laser ablation? This guy from Israel, 1 point drop, just a small study, they keep going. And how about this electroporation? It's coming from Braham. And you know what is? You go there, you put your feet on the pedal, and some electrical magic like Tesla, that's boom. And I have to get to Wikipedia because I don't know what it means. But it means that you apply a pulse and the cells die. And it's this procedure like this. Simple, elegant, get out of the papilla, and you start putting your feet on the pedal and burn, burn, burn. This is so cool, man. Just, you see, open up. By the way, you're not going to see those electro pulses there. This is going to be like wherever. And then you're not going to see these. But this happens. It's good. They already proved that. And they have this first study similar from the Dutch study, and you see here, after 12 months, 88% of patients are out of insulin. They're progressing. You know more? Why not use vapor? This is an approved FDA technology for Barrett's. So you block ahead, you block before you start, and let's go sauna. Okay, sauna it is. You see that? Look at this. We are vaporizing the things. In, if not in, cryo. Go cryo. So it is, my time is now, it's gone. It's impossible to get in 10 minutes. I will stop, and I'll just stop with, again, Thompson back to stage, magnetic. Open the magnet through the channels, couple them. In day 7, you're gonna have an anastomosis. It seems it works. Man, 4 hours. Some of the most experienced endoscopists on earth to do a procedure, you stop. You go back to bench, and then you have a hybrid technique that is laparoendoscopic. Open a hole, put a magnet, then go by endoscopy, couple them together by laparoscopy, 20 minutes procedure, everything changed, same results, blah, blah. And I will see Roman is doing this on the sleeve gastrectomy people with duodenal, and I will win like this. You know this guy? I know this guy. I don't remember how many times we battle against each other, endoscopy and surgery, and the guy is embracing magnetic anastomosis. I just love him. Michel Gagné, gentlemen, his own company, doing magnetic anastomosis. So that's something there we have to see, but look at those results, sleeve patients with duodenal anastomosis, that's brilliant. So stop here, it's 3 years in infancy, very promising, because on the future, we already have the stomach remodeling. Then we do the anastomosis. Hey, surgeons, be aware, we are in the game. Gentlemen, thank you very much for your patience. Have a good day.
Great presentation, Manuel. And now it's an honor to introduce Christopher Thompson, who is our next speaker. Christopher is a professor at Harvard Medical School in Medicine. He's going to speak on endoscopic third space application for the treatment of endoscopy.
Thank you. Always a hard act to follow, Manuel. Good to be here. Slides? Oh, okay. Perfect. Here are my disclosures. Those yours? Excellent. So third space. Third space really originated here with tissue resection, right? And you have typical ESD on the left, and on the right we have a stir procedure, which should be being played. Yeah, thank you for the clock. Can we resume the slide? I know, right? There we go. Thank you. So, and you can see the basic techniques here of marking, lifting, and then doing an incision and dissecting. And this really came from Japan in the early 2000s. Then they developed tunneling techniques as well to resect lesions. And this is a stir procedure, submucosal tunneled endoscopic resection. So these techniques, again, for tissue resection, that was kind of what they were primarily developed for. Then they were modified so that you could do myotomies for the treatment of achalasia and for gastroparesis. Well, there are several ways where these third space techniques can really help us in treating obesity and in bariatric endoscopy. It can augment existing bariatric procedures, or it can really lead to the development of entirely new procedures. And here are some examples. So they can help with tissue preparation to promote healing. And this really was initially developed, we were using it for fistula closure, where we do endoscopic full thickness resection for fistula takedown. We'll talk about that. And they can also help provide better durability for revision of gastric bypass in the TOR procedure with ESD TOR. We then started using this to treat existing pathology, and that was stenosis of the sleeve gastrectomy. And we found that we could do tunneled stricturotomies or disruption of that scar tissue, even in the submucosal space. We'll talk about that. And then we can also use it to alter normal physiology to get unique treatment effects in doing myotomies of the antrum. We'll start with tissue preparation. So gastric fistulas, we've been closing those for a long time. This is a case from, I think, 2006. And what we used to do is kind of ablate the mucosa with APC, and then here we're using the old ENDOSCOPIC device, this is before the overstitch was available, to do interrupted sutures to close this fistula. We did a series of 95 patients with this. We had a 95% success rate, initial closure. However, 65% of these reopened within 177 days. So clearly it wasn't very durable. And you can see how we used to have to pair those sutures up and then go down and tie them afterwards. So, now we have the ability to actually prepare the tissue more effectively. So we do endoscopic full thickness resection. You're going to see that in the video here. We start by lifting, by injecting fluid under the mucosa. Then we do a circumferential kind of ESD incision, and then we'll dissect that out. Then we'll use a forceps through a snare to pull this in and do a full thickness resection of that fistula. So you can see the data here. This is a retrospective series of 41 patients, and we're comparing the APC suturing technique to the EFTR technique you're seeing in the video here. And we had a 20% successful closure rate with the older APC at 10 months versus 56%. So clearly, you're getting kind of better results with the more aggressive tissue preparation. Additionally, if you look at the size of fistula, none of the larger fistula remain closed with the APC technique, where about half of them, 50% of them, remained closed with this technique. And large was defined as greater than 1 centimeter. So you can see, again, kind of how that technique could be pretty helpful. What about preparing the tissue for TOR? So transoral outlet reduction has been around a long time. We did the first case in 2003. We then did this randomized sham-controlled trial, again using that barred endocinch, which is no longer available. It was a suction-based suturing device, so it only would place the stitches in the submucosa. It couldn't go into the muscle. And we don't have time to cover all of these studies, but what I'm going to do is kind of show you the transition and how we got better results. So that initial trial, it was significant, provided level 1 evidence. It was better than sham. However, it was only a 3.5% total weight loss. We then got the full thickness suturing device. This is the Gen 1 overstitch device. And we were able to get up to a 6% total weight loss. So suturing, putting the sutures deeper into the muscle got twice the weight loss. We then started doing purse string sutures instead of interrupted, and we got up to about an 8.6% total weight loss. So we keep improving this procedure, and that really is durable for 5 years. So this is data from a 5-year study, 331 patients, showing that 8.8% total weight loss is maintained at 5 years, and we actually have 10-year data at DDW showing it persists out for 10 years. Well, what about third space technique? So this is what we can do now. So this is using a hybrid knife. So there's a water jet that puts, instills the water under pressure into this area because it's very scarred. You really need to be able to inject the water under pressure. And we do a circumferential incision. And you can do this pretty quickly when you get used to it. It should be less than 10 minutes to get around on a normal anatomy. And then we ablate that intervening mucosa with APC. But now what we're doing is we're able to suture directly into the muscle, right? And into some mucosal tissue there. And then what we do is a reverse purse string. We put in about 14 sutures. Spreads out and disperses the forces quite nicely. And we're not going to show all of those here. We'll just show a few. And then we size it over a balloon. So this is our current technique. You kind of rotate as you get halfway through and then continue. It's important not to cross the sutures. You want to not lock them. And then we size it over a balloon, and you end up getting a very durable surgical result here. This is permanent, right? So now we go all the way from having about a 3% total weight loss to getting a 12% total weight loss at 1 year. And 5-year data is coming up on that. So what about addressing specific pathology? Well, next we were using this to treat sleeve gastrectomy stenosis. And you see this is a case of a 22-year-old with a laparoscopic sleeve in 2017. they had excessive weight loss and malnutrition. And in the video here, this is quite a stenosed and somewhat angulated sleeve. So this is one of the harder type of ESDs, or third space tunneling procedures you're going to encounter, because the tissue is extremely fibrotic. As you can see here, it's very white, very dense, and fibrotic. However, this works tremendously well in patients that have failed pneumatic balloon dilatation, and really their only other options may be a surgical seromyotomy. So you can see very dense, but just taking down the submucosal fibrosis, look at that was without even dissecting into the muscle. It was substantial change. And then we dissect into the muscle as well. And you can see here it's a 77% clinical success rate at 1 year, and only 23% of these patients ended up needing a surgical revision. Finally, what about altering normal physiology for unique treatment effects? Well, and Barham did a great job already describing gastric physiology and how ESG kind of affects that. So there's 3 major phases here. You have storage via fundal accommodation, you have mixing, grinding, breakdown of food in the body, and then the antrum, you have that antral pump, which empties the stomach, right? And different procedures kind of affect different parts of gastric physiology. The old original pose just addressed fundal accommodation. All the plications went into the fundus. The intragastric balloon and ESG really focus on kind of that second phase of kind of mixing, breaking down of food. And the transpyloric shuttle focused on gastric emptying and kind of addressing the antral pump. So we developed a procedure called the GEM procedure, which basically is a pylorus-sparing antral myotomy. So we leave the pylorus intact, we don't cut it, and we take the entire antrum and run a couple of myotomies in the antrum. So it's the opposite of a G-poem, and our goal is to paralyze the antral pump. And then we do a running suture or a belt, and then do a modified ESG. So this is the series of our first 6 patients, and we see the 6-month follow-up. We had a 19.5% total weight loss, which was phenomenal, and 100% of patients had 10% total weight loss. And if you look at the actual gastric emptying, the emptying time, the T1 half time went from 90 minutes to 204 minutes. With the GCSI score, the only subscale that was changing was the satiety subscale. So there was no nausea and no vomiting, which is very interesting. That's because we're not affecting fundal accommodation, we think. And this is what the technique looks like. So again, we're at the incisura. We're going to go the entire length of the antrum. So first we start by tunneling. We do our mucosotomy to gain access to the submucosal space. And then we're going to tunnel. Now this is a little more difficult than a regular G-poem because the tunnel has to be very long and it's an unstable position because you're kind of looping in the body of the stomach there. But the end is easier because you don't have to climb up. So we leave that pylorus intact. And then we're going to do a long myotomy going distal to proximal. And now we're actually doing 2 parallel myotomies. So you kind of see this is very long. It's usually about 9 centimeters in length. And then we'll repeat that. Now, sometimes we'll actually do full thickness myotomies. We've stopped doing that because the patients tend to get omental hematomas and it causes significant pain and we have trouble getting them out of the hospital. They usually stay for 2 or 3 days. Whereas if you don't go full thickness, they go home the same day. So that's pretty much what that looks like. Additionally, we've now moved on to doing something called the bariatric endoscopic antral myotomy, or the beam procedure, which actually we do no suturing with. We just do the antral myotomy and we can clip the tunnel closed, right? So it's a lot less expensive. It's actually faster than doing an ESG. We're finding that at 6 months, these patients aren't out a year yet, that we have almost an 18% total weight loss, which is quite encouraging. Again, the GCSI, there's only change in the satiety subscale. There's no nausea and no vomiting. We're getting similar changes in gastric emptying. And if you're worried these are too complicated, there's technology on the way that are going to make these a little easier to perform. And there's some robotics, which we hope to be able to show next year as this is going into clinical trials in the US in January. So in conclusion, third space techniques are making their way into bariatric endoscopy. These techniques appear to offer improved durability, greater weight loss, less variability, and potentially lower cost. And training and certification processes are now the next hurdles to broader adoption of these techniques. Thank you for your attention.
Chris, would you stay here, Chris? And may I ask all the other speakers up here on the stage, Roberta and I, we will step aside, and you can answer the questions of the auditorium. So are there questions?
No comment.
We can ask ourselves question if you want, Christine.
Yes, but there must be questions.
I actually have a question for Chris. Haha. Usually, endoscopic procedures have been thought to be reversible, and that's something that we like. And not to last forever is something that we like because it's a chronic relapsing disease. So if you're doing a myotomy, you're cutting tissue. Aren't you worried that this is something that is moving towards irreversibility?
Yeah, that's a good point. So these myotomies are likely not reversible. Yeah. So with the initial trials, we made sure we were doing these in people with higher BMIs that could qualify for a gastric bypass, especially if they develop symptoms of gastroparesis. However, because obesity is a chronic disease and it's quite tenacious, I think that's actually an advantage of these procedures, right? You don't have to necessarily keep coming back and retightening them or escalating from a ESG to a sleeve to a bypass, potentially, if you really get good durable results with this. But you could also view it as a transition too, where you start off with the myotomy, and if 10 years later they need something, you do an ESG, and you stay minimally invasive as long as possible before you need to go into surgery. So, time will tell, but the patients have been very happy, and I think they kind of value there's a one-time procedure if that's possible, but I still doubt it. I think that 5-10 years down the road, obesity is so tenacious they'll need something done anyway.
We have one comment, please.
So in fact, I can ask questions to all, but first with Mohit. So do you recommend endoscopy before the swallowable balloon in all, or you don't?
No, we do not do any endoscopy before the swallowable balloon. We obviously take history to rule out, if the patient has some significant lesion inside the stomach. But this discussion has been done quite a bit now, and we have a lot of data to support. Even the US FDA trials in US do not mandate upper GI endoscopy before that.
So aren't you worried about any subepithelial lesions and all those stuff?
See, for the patients who have this concern, you can offer them an endoscopy. There is no problem in doing that. I mean, if by history we feel that there is something there inside where we might have a lesion which could bleed, or maybe patient has chronic gastritis, but usually I would not do an endoscopy.
Okay, thank you. So to Barham, so what's your take on doing APC of the antrum with ESG? Do you have any data on that?
So we have an ongoing randomized trial looking at APC and ESG. And with that trial, we're starting, because of the data that I showed, that the delay in gastric emptying comes from the magnitude of the contractions that initiate now from the antrum rather than from the body. So now we're trying to shorten these contractions further to delay gastric emptying further. So with that trial, we're using APC all the way from 2 centimeters from the pylorus all the way to the fundus of the stomach, and we're doing the full imbrication from the antrum all the way to the fundus. It's blinded and randomized, so we will find out soon. But again, as Chris highlighted in his presentation, we're getting better. The techniques are getting more advanced. And I could tell you it's blinded, so I don't know which got which, but I'm looking at these patients at 6 months, and they're breaking the 20% total body weight loss. So we're pushing that closer and closer to sleeve gastrectomy type of weight loss. And we're going to continue to do that as these things continue to mature and evolve.
So to Chris, it's a great idea of doing this. The incidence of strictures, of course, the short-term follow-up, are you worried about the stricture in the long term when you do a myotomy? though you are not doing the pylorus.
Yeah, we're not seeing any strictures as the patients are quickly approaching 1 year now. I think that where we see them, though, is in the revision procedures, so the transoral outlet reductions. We have to be very careful, and why we started sizing it over a balloon was we had about almost a 10% stenosis rate. So that's why we started using that balloon to make sure we didn't get it too tight, and now it's dropped down to about 2%. So, but I've not seen it in any of the primary procedures.
Thank you.
Any other question? Yeah, one from here, and then another one there, and then I think maybe we will close because we are going around.
Thank you for the good lectures. I have just one simple question to Dr. Nitol. How can we manage the CBD stones troubles after the such the endovascular systems? Have you ever experienced such troubles?
So if I understand correctly, how we manage CBD stones,
CBD stones
with a sleeve in place?
Saturating the devices of the endovascular, yeah.
That's a fair question. If it is DMR, we just go after the papilla, so it's clear. If you have a prosthesis inside, like we have the endo barrier, you have to remove it.
Okay.
Easy like that.
Mm-hmm. So in that
Easy
case,
like,
you replace the endovascular again after the treatment.
First we have to remove, and during the procedure we didn't saw an increase of gallstones or pancreatitis or something like that, because the material is Teflon, so nothing adheres there. So it creating problems to get to that. We didn't saw that. And if you have a problem, just take it out. That's it.
Thank you.
Very quick question, okay?
Sorry. Okay, thank you very much. My question is for Dr. Mohit. Sorry. Your experience with the swallowable balloon is quite impressive. Mine is quite humble. In my experience, I had about 10% of patients who did not tolerate the balloon. It varied from 5 days to 2 weeks where I had to go back in and take the balloon out. It was in the perfect place. It was not doing any obstruction or so. The diversity of patient did not let me know which I might anticipate that he will not tolerate the balloon. In your humble experience, your great experience, do you have any hints about who would not probably tolerate this kind of swallowable balloon?
Good question. So just wanted to ask, you're talking about your own experience with the Allurion balloon or with other intragastric balloons?
No, other way.
Other, yeah. So first of all, first thing first, the amount of serious adverse events and even side effects like nausea, vomiting, and reflux would be very less with the Allurion balloon because of the material with which it is made, number one. Number two, I do not offer these balloons to patients who have very severe GERD on history, who have very large hiatus hernia or even, hiatus hernia, which on endoscopy is grade 3. I would not offer them the balloon. Instead, we, tell them that you might have more symptoms with this balloon if you do it. And the good treatment for that would be a gastric bypass. But if the patients are really very serious about the balloon, what I usually would do is keep them in the hospital for 48 hours of the balloon, hydrate them very well, and give antiemetics inside hospital. And believe me, almost 100% of them go home very nicely without any problems. So, you need to have a very dedicated team to manage these patients who have nausea, vomiting, and problems after the balloon. In any which ways you bring them inside the hospital to give them a general anesthesia to remove it, the better thing would be give them a 48 hours of an injectable trial inside the hospital, hydrate them well, give good prokinetics and antiemetics, and then, most of these patients would go home without getting the balloon removed.
Thank you very much.
Thank you very much. We now close the session. I thank all of you for your excellent presentations. Thank you so much for coming. Really, I'm so honored with that, and I enjoyed it a lot. So they told me that in building 5 we'll have a break, and you can find a buffet and a coffee break.
Me and my
never stop saying hello.